Okay, today we are going to start a topic cone beam computer tomography or CBCT. I am Dr. Saurabh Srivastava, reader in the Department of Oral Medicine and Radiology, BDS University, Lucknow. So, as you have all gone through the topic of computer tomography, as the history says in computer tomography, it was developed by Hounsfield and Cormack in the year 1972. But 10 years later, CBCT technology, which was developed, it first came into use for angiographic purposes. For dental use, it was taken into account in the 1990s, not before that time, because the machine was bulky before that time. So much more advancements were made to make it apt for use in dentistry or in the dental office. So it came in around 1990s. So these were the machines which were used for computer tomography, where the patient was positioned in a supine position in the machine, and the circular ring-like structure, which is called as the gantry of the machine, patient's head or the area where the imaging was to be made, it was positioned in that area only, because over there rotating detectors were there and the X-ray source was also there in the gantry region only. So what happened in this CT or computer tomography, the images which were acquired, they were in the axial plane and these were known as slices. Later on, with the help of computer, these axial slices were reformatted to produce the images in coronal plane, sagittal plane or in the panoramic orientation. Three-dimensional imaging was also possible with the use of softwares. But the basic data which was there, it was these axial slices which can be later converted into the frontal sections or the sagittal sections. This was in computer tomography. Okay. With the help of the computer tomography machine, various Hounsfield units can be assigned to the structures which were imaged, just like air, water, muscle, the fibrous tissue, cartilage, bone, in which the trabecular bone, cortical bone, the dentine and enamel. These have been given various numbers. These numbers, they designate the Hounsfield units, which will tell us what is the density of that particular object which is there in the image. So just like air will have a Hounsfield unit of -1000, means it is less than water, which has been said to be a standard Hounsfield unit of 0. Then positive Hounsfield units will increase as the density of the structure increases. Now, this was with the computer tomography machine. What was the need for a special purpose machine for dentistry only? It was because the computer tomography machine, it had excessively higher cost. Because the machine was a bigger machine, it utilized the basic components in large numbers also. Okay, there was high radiation exposure in that machine. It was not meant for dental use or use for a very specified or limited area. That area which was exposed in a CT machine, which was much more than that needed for dental use. Motion artifacts were much more in a bigger machine than a smaller one. And due to the size of the machine in computer tomography, it will need a larger space to be installed. So these were some of the aspects of computer tomography machine which needed the development of technology to be utilized for specially dental purpose. And as we have discussed previously, this computer tomography in the cone beam form or the cone beam technology, cone beam volumetric technology, it was utilized primarily for the angiographic purposes, that was taken up for the dental use also. So as the name suggests, the cone beam technology will utilize the beam in the form of a cone. In the computer tomography, usually the beam is either in the form of a pencil or in the form of a fan. It is never three-dimensional beam. Cone beam means that the beam is in the form of a cone, which is itself a three-dimensional area, which is covering a three-dimensional area. So what is the principle behind this cone beam computed tomography. Now, as we have seen, the CT scanner, it has an X-ray source and a detector, and they are placed in a ring-shaped gantry, which has a rotating object, which is rotating in itself. So, with those rotations, slices are produced as images for the area of interest. Now, the cone beam scanners, these will have two-dimensional digital array of detectors. As you see that any gantry will have an X-ray source and a detector. These two will be present in the gantry. These detectors, their numbers, their positioning itself will determine the level or the staging or the evolution of the CT machines. And the beam shape from the X-ray source will also determine the stage of the CT machine or in which level of CT we are utilizing. The 3D X-ray beam with a circular collimation will give the resultant beam in the shape of a cone, because in this the collimation is in the form of a circle. So as we have studied in the intraoral periapical radiography and its machine, that collimation is done through a lead line tube in that machine, where we need the area of interest, because the region of interest for IOP machine will be the tooth. We don't want any excess radiation to be exposing much more tissue rather than the area of the tooth and its adjacent tissues. In this case also, the cone beam or the shape of the beam to be present in the form of a cone, we need a circular collimation. So this X-ray beam which is produced in 3 dimension will be in the shape of a cone only. In this, a quick volumetric data acquisition of the region of interest occurs. It means that if we are producing a beam which is in 3 dimension rather than 2 dimension, we are exposing the whole structure or the region of interest or the area of interest at one time. So if we are exposing it at one time, we are taking up more and more data from the area at one time. So there is quick volumetric data acquisition of the region of interest. After acquiring this data, the image reconstruction is done by a computer by extracting certain voxels and eliminating the effects which are not desirable. So we say that it will utilize the cone beam volumetric technology. The cone shaped X-ray beam, it is there in place of a fan shaped beam which was present in the computed tomography scanners. The presence of a square two-dimensional array of detectors is there in the cone beam CT scanners. It will require minimal amounts of generated X-rays. So if we are acquiring larger data size in a very small time or at one exposure, we do not need excess time. So that means we are reducing the exposure also. So it is seen that in 10 seconds of time, a 360-degree rotation of the machine round the head will capture around 288 static images. That means we have acquired enough data for reconstruction. So this volume data can be acquired in a single rotation of the beam and sensor. As you all must have seen the OPG machine in the college. So this data acquisition in the OPG machine is on the film or the sensor which is present, and it is again seen on the computer screen after the acquisition, and the OPG is seen on the screen. Similarly, over here, the volume of the data which is acquired by a single rotation by the beam and sensor will be seen on the computer screen. So the conventional scanner will provide a set of the consecutive slices of the patient. We have seen previously that axial slices will be generated in the conventional scanners, while the CBCT scanner will give us a volume of data. It means the slices which were seen in conventional CT scanners are not the same as in CBCT scanner, because over here the cone beam is there which is not creating slices. Instead, it is giving volumetric data or the data in bulk. Coming to the machines, how do they look like? As the CT scanners, previously what we have seen that the patient was taken into the CT scanner in supine position. So the patient lied on a table and it was taken away into the gantry where the X-ray source and the detectors were present and the imaging was done. But with the advent of technology and reduction in the space, the CBCT scanners, they were made similar to the OPG machines. So there was no need for the patient to be in supine position. The patient can sit or stand in the machine, and then the scanning can be done for the structures in the orofacial region. Now these are certain pictures or images which will be generated on the screen after taking the or acquiring the data set from the CBCT machines. These are the pictures which are seen after the reconstruction phase. So we'll study later on what happens. Now over here, how does the image acquisition take place? So a simple flowchart is there where the rotating X-ray source will be there and it will produce a basis image which is there as a single image first of all, and these multiple basis images which will be collected as a projection data. So the basis image will be the single image produced by the rotating image source or the X-ray source, and such multiple basis images will form the projection data. This projection data will be seen as a 3D volumetric data set and will be utilized for the primary reconstruction of the images. Now the primary reconstruction can be in the three orthogonal planes like the axial plane, sagittal plane and coronal plane. Now the axial plane is something which is said as the cross-sectional view of any object, that is the axial plane. Sagittal plane, as you all must have seen, is the antero-posterior plane. It is the sagittal plane. You must have seen in orthodontics the sagittal plane, and the coronal plane is the frontal plane, where you see the objects in the frontal view. That is the coronal plane. And these orthogonal planes can be utilized for the multi-planar reconstruction of the images. Okay. Then what are the various parts of this image acquisition? So the image acquisition is done basically by four things. First is X-ray generation. Second is image detection system. Third is the image reconstruction. And fourth is the image display. Okay. Then what is X-ray generation and how does it take place? In this, the patient's positioning in the machine will be either sitting, standing or maybe supine, but the basic concept here lies in immobilization of the head so that the patient's head should not move while the exposure is made. That will distort the image. So the second thing is the X-ray generator. Now X-ray generator is utilized in such a manner that the exposure of the tissues is minimized. So to make that possible, pulsed radiation beam is utilized. It means whenever the acquisition is taking place by the detectors, certain algorithmic changes are certainly taking place at the same time, simultaneously, for the formation of the image at the time of acquisition of the image by the detectors. So that time when the exposure is not needed and algorithms are taking place, that radiation is stopped. So pulsed radiation beam is utilized along with the principle of LRA, which is as long as reasonably achievable. Okay. Previously it was LR, ALARP, reasonably possible. So And the third thing is the automatic exposure control. So the automatic exposure control is another functioning of the computer system within the machinery, which will control the exposure parameters like the kilovoltage and the milliampere seconds. So according to the tissue type and the tissue characterization, automatic exposure control can also take place in certain machines. Then the X-ray generation will also have a factor of scan volume. How much volume of the scan we want to scan, volume of the tissues. So it will certainly need the field of view. That means how much area we want to scan. We want the FOV or the field of view. It will depend upon the size or shape of the detectors, how much we can scan. The detectors should be present in that size and shape. Collimation of the beam. How do we collimate the beam? So that such a beam is produced which will give us the shape and size which is required to be for the field of view. Third will be the projection geometry. What will be the distance of the object from the source, object from the sensor? How can we produce the maximum image or the area of interest to the maximum imaging capabilities with minimum radiation hazards? Then certain scan factors are also there which determine the X-ray generation, just like the frame rate which is applicable in CBCT, which is the speed of acquisition of the individual image. So higher the frame rate, lower will be the noise. Noise is seen as graininess in the image. And if we keep the frame rate higher, it helps in reducing the metal artifacts also. So this was the frame rate, and certainly second point is the scan timing. If we reduce the scan timing shortly, then it can also reduce the X-ray generation or the generation of the X-rays or exposure of the X-rays. So if we need a 360 degrees rotation for a particular area of interest, but if the area of interest or the field of view needs to be smaller, we can reduce the trajectory of the machine, we can reduce the exposure. So this is one pictorial depiction of the X-ray source, the trajectory, which is the movement around the head, axis of rotation, which will be along the head only, and the detectors which are present in 2 dimensions. Okay. Now second, we come upon the image detection system, what detectors are utilized. So basically two types of detector systems have been utilized in the CBCT machines. They may be image intensifier tubes or charge coupled devices in combination, or they can be flat panel detectors like utilization of commonly used cesium iodide. Scintillation crystals are there. Now, in this, the voxel size is also very important. The voxel size will depend upon the X-ray tube and the focal spot size. Lower the focal spot size, the better will be the voxel size. So, sharper will be the image. But to get a lower focal spot size in an X-ray machine or the X-ray generator, it increases the costs. So, an optimum focal spot size is desirable. The X-ray geometric configuration, secondly, is also responsible for producing the voxel size, matrix and the pixel size of the solid state detector. Means what detectors we are utilizing, what will be the matrix of detection and the formation of pixels in that detector itself. That will also be very, very important in creating the voxels and their size in turn. In this, if we can reduce the object to the detector size, the distance between the object and the detector, and increase the source to the object size, distance, then it may also minimize the unsharpness which is produced geometrically. As we have seen in the basic principles of X-ray projection geometry, that the source to object size can be increased and the object to detector size to be decreased to get a sharper image. Then another factor in the image detection system is the grayscale. Grayscale we have seen in radiography to be the presence of visualized contrasts, the areas of white, gray and black. How much differences can be seen or can be visualized on the screen. It will depend in CBCT, it will depend upon the bit depth. There is something called as the bit depth of the system, which will determine the number of shades of gray available to display the attenuation. Attenuation is the X-ray absorption in the tissues or in the medium through which it is passing through. Then bit depth, which is talked about, basically bit depth of 12 is taken into account commonly for the CBCT machines, and it will show us 4096. That means 2 raised to the power of 12 shades of gray for the contrast purposes. So this much can be visualized. Even more is available nowadays. Okay, then we come to the image reconstruction. Now, image reconstruction, it will take into account the primary reconstruction first of all. When image is acquired, the acquisition phase is over, the reconstruction will take place. The reconstruction, it has acquisition stage and the reconstruction stage. The acquisition stage is done in the acquisition computer where the images are corrected for the imperfections at the pixel level. All the images which are taken or the data which is collected in the acquisition computer, over there the software will correct the imperfections at the pixel level. That means wherever the pixels are missing, it will put up certain pixels by taking into account the adjacent pixels. Then reconstruction stage takes place. It is in another computer where the data will be transferred via a LAN cable, and this workstation or the reconstructions computer which is present adjacent to the acquisition computer in CBCT machines, this will take into account the corrected images, and it will these images will undergo radon transformation to make a sinogram, which will be a representational image first of all, and then these sinograms which are taken up for certain rows of pixels, they undergo Feldkamp algorithm to make a sinogram reconstruction image. Now this sinogram reconstruction image will be taken up as a single volume for visualization or display. Okay. Now this is the flow chart for acquisition and reconstruction phase which are there in CBCT. In acquisition, the image collection, correction, and then in reconstruction stage, the sinogram formation and the Feldkamp algorithms take place to make the volumetric data set. Okay. Then the image display or the reformatting also will be taking place. Along with this, display will be there on the computer screens, and the data which is present on the computer screens will be in the phase these orthogonal planes like the axial, sagittal and the coronal, as we had discussed previously, and the multi-planar reformatted images or multi-planar reformation will take place by the softwares, where non-axial two-dimensional images can be taken up and shown on the screen. Along with this, there is one technology or one software where 3D volume rendering takes place. It also happens with the software only. The three-dimensional volume rendering may be indirect by the use of segmentation technique, or direct where the maximum intensity projections are utilized. Okay. Then the certain effective doses from various modalities which are utilized will show us that CBCT is having much lesser dosage of radiation injury to the tissues than CT maxilla, mandible, and higher than the panoramic screen films. So the CBCT will be taken up as an indicative method of radiography or imaging, where we would not go certainly for the CT imaging, rather than CBCT should be taken up for the benefit of the patients, and where we do not want any overlapping structures to be seen, and much more in-depth study of the anatomical details of the patients are needed, we will go for the CBCT imaging rather than the panoramic imaging. Now, uses in the maxillofacial region, what all uses can be there? These will be the indications which are for CBCT in the maxillofacial region. First is trauma or the traumatic injuries. Second, tumors which are present in the hard and soft tissues in the orofacial region, in which the extent is not clinically decided. Then in cases of implant placement or implant planning and assessment and post-implant uh, evaluation also can be done. Then localization of various structures or foreign objects, infections and their extent, TMJ pathologies, then sinus diseases can also be very easily determined by the use of CBCT technology. Then in cases of orthodontics, where we need the various views for orthodontic purposes can also be taken up by the CBCT machines. And for counseling and educational purposes for the patient's own anatomical details can be reproduced by 3D printing by taking the data in a volumetric form by CBCT and printing that data by use of certain plastic objects to produce the models, patient's own models. Okay, as we had talked about the various uses of CBCT, the malignant lesions which can be seen on the images, like the panoramic reconstruction is being seen in the lower images and the 3D reconstruction in the upper images. We can see the level of bone loss and what type of bone loss is there. We can see the extent also very clearly in the three-dimensional pictures, and it can easily be told to the patient, explained to the patient also. So 3D reconstruction images are also helpful in counseling of the patient. So implant site assessment, the accuracy of this linear measurements which are there for implant assessment, we can see them very clearly in CBCT and can be comparable to the multi-slice CT when we are using it for implant planning. Various slices in case of implant planning, the slices are taken up of mandible or maxilla in relation to the teeth, because in that area we need these teeth only to be seen in slices, how much space in between or adjacent to the teeth we are having, so that we can place the implants in that region. Whenever we are taking any case for implant planning, we need first of all to determine whether any vital structure like the sinus flow, like the mandibular canal, or any thickness of the bone where we are planning to place the implant is there or not. Then we have to decide the length and width of the implants. Then third thing, we have to see how much amount of space after placing the implant will be there in between the natural tooth and the implants. So all these things can be taken up and The surgery of implant can be planned well in advance. Along with this, the CBCT imaging or this CT imaging, it will also help us in simulating the surgical procedures also. So whenever imaging is present at hand, we can utilize it in various ways as we need and desire. Okay, then there is localization of any anatomical structure, tooth, or a foreign body, where we are not able to localize that thing in two-dimensional imaging like IOPA or OPG. We can utilize the CT scanning or the CBCT scanning. CT scanning, the term I am utilizing for the dental CT, that is CBCT only. Wherever the CBCT facility is not available, we can go for the CT scanning facility because CT scanners may help in that case for the patient to visualize certain areas which are not seen in OPG machine or the OPG scan. In TMJ region, as it is visible with various overlappings and superimpositions of other structures in OPG and in sectional TMJ scanning also various superimpositions are present. The reconstructed images or of CBCT for TMJ examination, they are having high diagnostic quality. That means we are able to see the whole joint, the osseous structures of the joint very clearly. The non-osseous structures can also be determined in the CBCT scans. And in this case, the examination time which is taken up for TMJ examination is quite less. You can see the TMJ which is seen in various sections in the CBCT image. We can see each and every slice of the TMJ when the volumetric data is acquired. All these images will be reconstructed. Then infections, as we had talked about, the local extension of the disease as in case of osteomyelitis and the relationship to the anatomic structures, these all can be detected by CBCT. In suspected cases where we are suspecting malignancy in infections, we can adjunct scintigraphy along with the CBCT. In periapical lesions, we can also take up the CBCT images to determine the exact source of infection, the length of the roots, the extension of the infection. Then in cases of fractured roots where it is not visualized on the IOPA images, either due to overlapping of the fracture lines, either due to the overlapping of the teeth parts itself. That means if the fracture line is oblique, usually it gets overlapped by when we are taking the IOPA films or IOPA radiographs. And when the vertical fractures are present, even on a mesial root surface or a buccal root surface vertical fracture may not be visualized on the IOPA film. So we have to go for the second aspect, which is the CBCT imaging. In case of orthodontics, we can reproduce the conventional cephalometric radiographs with a similar precision and accuracy by CBCT also. So this machine can also be utilized for orthodontic purposes. These images you can see over here. Then we had talked about the 3D printing or the rapid prototyping, which is very good tool nowadays to explain to the patient about his or her own anatomical structures. What structure the patient has and what all can be done to give better outputs or the better results of treatment to the patient. So this structural detail, which is almost accurate when a CBCT image or the volumetric dataset imaging is taken up for 3D printing in a plastic based substance. Now you are able to see a patient positioning video where head immobilization, the various vertical and horizontal planes are to be aligned when patient is positioned. Then the machine is moved around 360 degrees rotation around the head, and in these two parts of the machines, one part will be having your scanner and the other scanner or detector, and the other will be having the X-ray source and the collimator. So these will be the basic aspects of your CBCT machine and the patient positioning, where the data acquired will be seen on the computer screen after its reconstruction. Then we come to artifacts. Various artifacts which are seen in CBCT machines, they are namely acquisition artifacts, which can be cupping type of artifacts which are seen by various metallic fillings or restorations or any prostheses which are present in the oral cavity on the teeth. The streaks or dark bands can be seen as acquisition artifacts. Then patient-related artifacts can be seen as unsharp image areas where the patient motion has occurred. Then scanner-related artifacts are seen where circular or ring-shaped streaks are seen when the scanner has certain discrepancies in detection or X-ray production. These images are showing the cupping artifacts, and the second one is showing the streak artifacts where the dark lines are seen. Then cone beam related artifacts where partial volume averaging is a type of artifact which is related to this projection geometry of cone beam technology, where step appearance will be seen. In this picture you can see the artifact arising as a result of undersampling. That means the adequate amount of data acquisition has not taken place. Then these fine striations in the image will be seen. This is due to undersampling of the data. Then cone beam effect will be seen as image distortion, streaking in the image, or a greater peripheral noise, because the beam which is produced as a cone will have a certain end also, and at the end of that beam the acquisition of the data is reduced. So we are going for a comparison between the CBCT and the multi-detector CT, which is the conventional CT scanners. So both will have similar requirements for electrical details. No floor strengthening is required in CBCT, but it is required in MDCT. Room cooling may not be required in CBCT, but MDCT requires it. Now, CBCT is very easy to operate and maintain with little technical training, but MDCT has much more operational costs. The cost of the equipment itself will be 3 to 5 times lesser than the traditional or conventional medical CT machines. The equipment is substantially lighter and smaller. That means the size of the equipment will be smaller. And the cone beam CTs will have better spatial resolution. That means smaller pixels will be seen for the images. So sharpness will be more. The images you can see for both the MDCT and CBCT. Lower contrast resolution will be there in CBCT, which is less discrimination between different types of tissues. Because CBCT will be using volumetric data set, this contrast resolution is a little drawback as compared to the conventional medical CT. Then air measurement is accurate in both CBCT as well as CT. In majority of CBCT machines, the patient will be seated or standing, and this open design of this CBCT where claustrophobia will not be there for the patient, and patient will be in comfortable position and will accept the modality of imaging better. The lower cost of the machine may be passed on to the patient in the form of lower fees also. And in terms of the radiation doses, it will follow the basic principle of LRA. As we can see, the medical CT will have more radiation exposure than CBCT, which in turn will have more than the conventional radiographic techniques. So to conclude, we can say that CBCT also provides accurate information as medical CT. There is improved diagnostics and imaging as compared to conventional radiography. Improved patient education because newer tools for patient education like the 3D printing or the 3D reformatting can be utilized, and it is less hazardous than the medical CT machines. So this was all with the CBCT, and you can put up your queries